This is PediaCast CME.
Welcome to PediaCast CME, a pediatric podcast for providers. And now, direct from the campus of Nationwide Children's, here is your host, Dr. Mike.
Hello, everyone, and welcome once again to PediaCast CME. It is a pediatric podcast for healthcare providers. This is Dr. Mike coming to you from the campus of Nationwide Children's Hospital. We are in Columbus, Ohio. It's episode 86 for June 20th, 2023. We're calling this one Care and Support for Children and Teenagers with Down Syndrome. I want to welcome all of you to the program. This is another one of those episodes that will be relevant for anyone who takes care of kids, regardless of your role in the healthcare setting. And that is because Down syndrome, also known as Trisomy 21, is very common. And you're bound to provide care and support for these patients and families on a regular basis. Down syndrome is the most common chromosomal disorder, with 3 copies of chromosome 21 in the nucleus of cells instead of 2 copies, hence the name trisomy 21. It has a worldwide incidence of about 1 in 1,000 births, a little more common here in the United States, affecting 1 in 700 births, which translates to about 6,000 babies born each year with Down syndrome. Down syndrome is also the most common cause of genetic learning disabilities in kids, and it has a tremendous impact on the lives of those affected and their families, which makes the care and support of these children, teenagers, and their families really important. In our usual PediaCast fashion, we have a couple of guests joining us today who are experts at supporting those impacted by Down syndrome. Dr. Murugu Manickam is a clinical geneticist and a Down syndrome specialist at Nationwide Children's Hospital. He's going to help us understand what causes Down syndrome, the typical features and complications of the condition, how it's diagnosed and managed, and best practices for transitioning teenagers with Down syndrome from pediatric to adult healthcare. Kari Jones will also be joining us. She is president and CEO of the Down Syndrome Association of Central Ohio, and she's going to shed light on the family experience and their need for support. What is life like in their shoes? What needs do they have? What unique challenges do they face? And what rewards do they reap? And how can we, as pediatric providers, anticipate needs and connect these families with local, regional, and national resources? Before we get to our guests, let's run through our usual quick reminders. Don't forget you can find PediaCast CME really wherever podcasts are found. We're in the Apple and Google podcast apps, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. If you like what you hear, please remember to subscribe to our show so you don't miss an episode. Also, please consider leaving a review wherever you listen to podcasts so that others who come along looking for free continuing medical education credit will know what to expect. Speaking of the education credit, it's easy to claim yours. And again, it is a Category 1 credit. Simply listen to the podcast, which you are about to do, and then head over to the show notes for this episode at PediaCastCME.org. You'll find a link to the post test in the show notes. Follow that link to Cloud CME, take and pass the post test, and the Category 1 credit is yours. We offer credit to many pediatric professionals, including doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and even dentists. And since Nationwide Children's is jointly accredited by all of those professional organizations, it's likely we offer the exact credits you need to fulfill your state's continuing medical education requirements. Of course, you want to be sure the content of this episode matches your scope of practice. Complete details are available at PediaCastCME.org. We're also on social media. We love connecting with you there. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. And we have that handy contact page at PediaCastCME.org if you would like to suggest a future topic for the program. Also want to remind you the information presented in this podcast is for general educational purposes only. We do not diagnose medical conditions or formulate treatment plans for specific individuals. Your use of this audio program is subject to the PediaCast CME Terms of Use Agreement, which you can find at PediaCastCME.org. So let's take a quick break. We'll get our expert guests settled into the studio, and then we will be back to talk about care and support for children and teenagers with Down syndrome. It's coming up right after this. Dr. Murugu Manickam is a clinical geneticist at Nationwide Children's Hospital and a professor of pediatrics at The Ohio State University College of Medicine. Kari Jones is president and CEO of the Down Syndrome Association of Central Ohio. Both have a passion for supporting children, teenagers, and families impacted by Down syndrome. That is what we are discussing today, care and support for kids and teens with this genetic condition. So let's give a warm PediaCast welcome to Dr. Murugu Manickam and Kari Jones. Thank you both so much for being here today.
Thanks for having us. We're excited.
Thank you very much.
Yeah, we were also excited to have you guys here to talk about Down syndrome. We did this on the Parent Podcast. I think it was like right before the pandemic. And we wanted to also do one for providers because there's a lot that we can say in terms of caring for and supporting those impacted by Down syndrome. I think a great place to start would be, even though we're going to talk about care and support, is sort of a foundation of Down syndrome. And so, Murugu, if you could just remind us exactly what is Down syndrome?
Sure. Down syndrome is a chromosomal disorder where you have an extra copy of the 21st chromosome. So the 21st chromosome is actually the smallest of all of our chromosomes. And what I often tell families is that the reason that kids with the extra copy can survive is because it is that small. If you, for example, have a extra copy of the first chromosome, it's so large that it ends up in a miscarriage if it does occur. And so that's the reason that the children will have issues is because that extra copy influences not just what's on the 21st chromosome, but probably influences all the chromosomes to some degree.
Really very interesting. And so it's chromosome 21. There's an extra copy. Is it a full copy or is it like a partial copy or is it variable?
Yeah, so for most families, it is a full copy. There are the rare patients, the very, very rare patients that have partial copies. But for most kids, it is that they just have the full extra chromosome.
Okay, and that's going to pretty much be in every cell of their body. They'll have that extra chromosome.
Correct, yeah. And so that is what the case is for 99% of kids. The 1% that are remaining are the kids that have mosaicism. So that is where it's not necessarily in every single cell. And a lot of parents really ask that question and are kind of looking for that because usually that we think of kids who have mosaicism as being more mildly affected. And in general, they are, but it's hard to exactly predict how much they're going to be affected.
And then, Kari, how common is Down syndrome? In the intro to the episode today, I mentioned that it's so common that pretty much anyone who takes care of kids is going to come across a family impacted by Down syndrome. But here in the United States, how common is this condition?
Yeah, so the current CDC statistics state that it's about 1 in every 700 babies that will be born with Down syndrome. I think everybody in our field is really looking to see if that statistic wavers at all as really pre-screening and testing becomes more prevalent and offered more frequently, and insurers continue to increase that accessibility prenatally. So that's been the number for many years now, but I think that we're all kind of anxiously awaiting to see if it moves one way or the other.
Yeah. So that's pretty common if we think about 1 in 700 births, probably one of the more common things that we talk about on this podcast. Mm-hmm. And we know that it's a little more common in the United States compared to other countries in the world. Do we have an idea of why that would be?
So it's probably a variety of reasons. One part that definitely is true is the prenatal care that's going to be involved, that for most families in the United States will have some degree of good prenatal care, and there can be complications associated with having a child with Down syndrome. But the other part would be that after birth and things like that, a lot of kids will have heart disease and other complications that they may not have ready access to surgeons and so forth. And so that may be one of the reasons that the numbers look a little bit different in other countries.
Sure. And then in terms of risk factors, one that I remember learning a long time ago was advanced maternal age. So if you're older, especially if you're 35 years of age or older and you have a baby, you're more likely to have a child with Down syndrome. Do we still think that?
So loosely, yes. But really that 35 number is a little bit arbitrary. It was really a number that was the risk for having a child with any trisomy equal to the risk of what is the complication of having a procedure like an amniocentesis. And so there is, certainly a risk as moms get older, but we also see that most families that have a child with Down syndrome, the mom's under 35.
We even see at the Down Syndrome Association of Central Ohio, teen mothers who have a baby born with Down syndrome. And I think that's pretty surprising to our community when they see that, because I think that 35 number, like you, kind of sticks out. And so when you hear of a 16-year-old that just delivered a baby with Down syndrome, people are very confused and surprised by that. But yeah, the current statistics show that 80% of the babies born with Down syndrome are born to mothers under the age of 35. So,
are there other identified risk factors that we need to think about, or is it really just sporadic and, you just don't know when it's going to happen?
Yeah, it really is mostly sporadic. There's a situation, though, where it can be slightly increased risk. So one is just having had a child before with Down syndrome. Then we do think that your risk is slightly higher, about double whatever your age-based risk is. But that's still, at age 35, is, I would just look at the numbers, like 1 in 200, 1 in 300, somewhere around there. So it's not significantly increased. But there are also the rare families that have the 21st chromosome attached to another chromosome. And so for the parent, that 21st is attached to another chromosome, and they have the normal complement of having 45 chromosomes, but one of them happens to have both 21 and something else attached together. But when they go to have a child, they're at increased risk for having a child with Down syndrome.
Okay. So if a mom had a baby with Down syndrome, subsequent pregnancies are a little bit higher risk.
Slightly higher risk.
Slightly. And then kids with Down syndrome, if they have a baby, are they always going to have Down syndrome?
They're not. There's not a lot of data, really. We know that most, or at least we think that most males with Down syndrome generally have some fertility issues. But females who have had children, they don't seem to have an extraordinarily high risk.
Very, very interesting. Okay, so let's talk a little bit about Down syndrome itself in terms of the physical signs, symptoms, complications. What does this condition look like?
Yeah, so, I'll look at it two different ways. So one is kind of what families will see in the prenatal setting, because I think that is what we're starting to see a lot more of, are families that know before the baby's even born that the baby has a high risk for having Down syndrome. So some things are that show up, like either in ultrasounds or, as Kari alluded to earlier, with some of the prenatal screenings that can be done, that you may find out as early as 10, 12 weeks that there's an increased risk. And it's important to always put that out there, that it's risk, not diagnosis. And so, now there's a what's called non-invasive prenatal screening, and they do a blood test on mom, and they can tell, again, around 8 to 12 weeks, somewhere around that range, that the baby has an increased risk for having Down syndrome. Often families will then want to talk to someone about that, get an exact what is this risk. And so the important part is for families to get early care, and so they can identify, is there an increased risk, or is it just a number risk, so to speak?
And we have seen families connect with us because they went to their 20-week appointment and they noticed maybe a congenital heart defect and some increased kind of, commonalities that you would see with a baby who might be born with Down syndrome. And so then they maybe waived the screening earlier in their pregnancy, but now feel compelled to get that screening and that testing done.
And those are called some of the soft markers for Down syndrome. So they can have what's called a small nasal bridge. And so it looks like their nose is a little bit flattened. And they often will have some extra skin on the back of their neck called a nuchal fold. And those can sometimes be markers for having a child with Down syndrome, but with other conditions as well.
But if you were to see those on a prenatal ultrasound, then it is going to be important to get the prenatal testing, just so that you can start educating yourself. You can there may be decisions that you want to make, and I guess the more information that you have, the easier it's going to be to make decisions and maybe get care and lined up after the baby's born.
I think it's difficult emotionally. I mean, that is in practicality makes perfect sense. We see that a lot of the time. Sometimes we see a mother who's 12 weeks into her pregnancy and she is all in. They are coming to resource group meetings and connecting with other moms, and the dads are connecting with other dads, and all of that is happening. And then on the flip side, we'll have a family connect to us postnatally who found out prenatally that there was a high likelihood, but they weren't really willing to accept that information until it was certain. And so we really see from the mental health standpoint, it runs the gamut with what families are willing to do. But I think when we see some common co-occurring health conditions like congenital heart defects, it is helpful to take those pieces of information, whether or not it's affirmed that the child has Down syndrome or the baby's going to have Down syndrome. They at least need to be prepping for some of that, because immediately post-delivery, there are going to be some things that need to be done. So, but yeah, I agree with you that it's something where it feels like the more education you have early on, the better. And I think that for most, that's how they feel.
Yeah, absolutely. And then after the baby's born, Murugu, what characteristics do we see that could kind of point us that this might be a baby with Down syndrome?
So, there's the traditional kind of facial features that we often associate with Down syndrome that we know may be seen in textbooks, but we're starting to also see a much larger gamut. I'll just say historically, a lot of the pictures that are in textbooks and things like that are of kids of European ancestry. And the features are going to be a little bit different at different ethnicities. And so we kind of have to think about that a little broader sense. But starting with the facial features, they have what we call upslanting palpebral fissures. So if you take a line from the inner part of their eye to the outer part of their eye, it upslants just a little bit. Often their eyes look like they're a little bit close together. I often describe their facial features as like everything's crowded into the middle of their face. And this often actually does reflect in the fact that they'll have some, noisy breathing. They have problems with the middle ear, things like that as they get older. Then there's the ones like Kari alluded to that will have a heart defect and maybe it wasn't picked up prenatally. And so they may have a murmur on exam. We used to talk about this single palmar crease, and it can be there, but it's not. You can have people who are just fine who have single palmar creases, and anecdotally, it seems like maybe half the patients actually have a single palmar crease when you look for them.
I'll add that beyond what you can see, I think it's also important for physicians in the community to know that families really appreciate when you can still talk about and see the child and see the features that are common among the family members. So I think that from our perspective of hearing from families, they really appreciate it when someone says, they look so much like you, because often there still are those characteristics that are, you appear to be related in that way, even if Down syndrome does have its own specific features.
Yeah, that really makes sense. And one of the things that we're going to talk about as we consider supporting these kids and families is really trying to normalize things as much as possible so that they don't feel different. They feel the same in as much as they can. And it's important to focus on the positive too, for sure.
Yeah. I think I have a brother with Down syndrome, and the first time someone said that he looked like me, I was not sure how to. It's just the first time someone says it, it's like, okay. But then, then I'm like, he does. He looks like my dad. He has features that look like my mom, and he does look like me. He does look like my brother. He also looks like he has Down syndrome too,
Yeah.
So.
And one of the way I sometimes will also say to families, the 21st chromosome's 1% of your DNA, the other 99% matters. And the other 99% is making up who you are as well.
Yeah, absolutely. I want to focus real quick on the heart defects because this program is really targeting pediatric providers and folks who are going to be taking care of kids with Down syndrome. And they're pretty common, right? And it's up like half of all kids with Down syndrome will have some degree of a congenital heart defect.
Yeah, about 50% will have a congenital heart defect, but it can be a really wide range. You'll see some kids who have pulmonary atresia as a severe form of tetralogy of Fallot, but it can range all the way down to just having an atrial septal defect or a ventricular septal defect, which, again, still may need some intervention, but may not be an issue in the short term.
Yeah, so that's going to be one of the sort of required referrals for all kids with Down syndrome, at least to initially see a cardiologist, probably have an echo done, and just to see if there are any defects related to the heart. And it's really going to be, your primary care doctor to have that knowledge that, hey, you need to get in to see the cardiologist.
Yeah, we'll talk about it probably going forward, but the AAP guidelines are really to get a echocardiogram before the baby is discharged.
Okay, that totally makes sense. And if you're in a large city with an academic medical center, that's probably going to happen. But if you're in a rural location and people may not be aware of newer guidelines, and so just something to keep in mind. And we will talk about the AAP guidelines for care of these kids in a bit. Other than the heart problems, what about problems with vision and hearing? Are those common with kids with Down syndrome?
Yeah, they don't tend to appear in the infants. It tends to be things that kind of come up later. Some will have some hearing issues on, for example, newborn hearing screens. But most often it tends to be conductive issues related to effusions of the middle ear. So they tend to be ones that can pretty well be taken care of, but you're right, that awareness is necessary.
And then what about the risk of infections?
A little bit of a mixed bag. There are some studies that have shown that there is an increased risk for infections, but it's often related to other things as well. Any child who's got a congenital heart defect is going to have an increased risk for infection and have complications from infections and things like that. Again, with the middle ear issues, they tend to get otitis media much easier. They can sometimes have some sinus drainage issues, things like that. There's also some evidence that they may not immunizations don't work as effectively in those with Down syndrome, but that's really an evolving area of research right now.
Yeah. And if that turns out to be true, it's even more important that the folks that surround that kid with Down syndrome are vaccinated so that you can prevent transmission from one person to another to someone who may be a little bit more susceptible.
Absolutely, yes.
Yeah.
One other one I would mention also in that early onset area is duodenal atresia. About 1% of kids who have Down syndrome will have a duodenal atresia, and so they will present with vomiting issues right after they're born because nothing's going to pass past the first part of the duodenum, which is usually where that defect is.
And that can be life-threatening if it's not picked up. And so just because a kid is vomiting, you really want to get the characteristics of the vomiting. Is it forceful? Is it projectile? Is there bile present? Is a kid losing weight, not gaining weight appropriately despite eating what would seem to be enough? So all things that to consider as a primary care doctor taking care of one of these babies.
So one other thing I would also say is, feeding issues are really common.
That's what I was just going to say.
Yeah, in infants with Down syndrome. So it can be a number of things. So one is that they do have low muscle tone. It's hard to get a good exam on newborns. They're going to have some degree of hypotonia naturally. But in children with Down syndrome, their muscles, and especially the muscles that are involved with swallowing and getting food into the esophagus and into the stomach, may be a little bit weak. And so they may have problems early on with feeding. So it's not uncommon for them to need a little bit extra time in a nursery or a NICU just to get the feeding part down. Some will even go home with NG tubes, and sometimes they even require G tubes. And even more so when you have a congenital heart defect. If they're having to spend a lot of energy just eating and it's taking a long time, that's tiring out their heart. That's not allowing them to grow. And so the NG tube, the G tube are all temporary measures just to make sure they get enough nutrition to get them to grow and get them big enough that they can get the cardiac surgery when they need it.
Yeah, so very, very important. And we definitely want to keep track of feedings and weight gain and all of that as primary care doctors taking care of kids with Down syndrome. Are there other medical complications of Down syndrome that we should be aware of as we're caring for these kids?
So the other ones that are in the AP guidelines are to check a thyroid level, TSH and T4. The newborn screen, thyroid screens are not necessarily enough for newborns. And then to also check a CBC, because they can have some early evidence for what's called transient myeloproliferative disease. And in most cases, it kind of goes away, and as the word transient would imply. But that is a group of kids who then are at higher risk for developing leukemia and lymphoma as they get older. So it's good to identify that risk at least early so that you know what to look for going forward.
Yeah, that makes sense.
I think this is really an important point to make for practicing pediatricians because it's often going to fall to the pediatrician who's covering a newborn nursery to sometimes talk to a family about a new diagnosis. And families remember these conversations. Kari can give you many, many stories about 20, 30 years on, and families still remember that first person who talked to them about the diagnosis. And, it could go any number of ways, but you want to try to do the best you can for these families. I think, and Kari kind of brought this up before too, it's one of those things of you need to talk to the family and you need to talk to them in a positive manner. Say congratulations. And that is really important. They just had a baby. It's congratulations, and then everything else after that. You can say, you have concerns and things like that. To have that positive tone really does make a difference to the family. Yeah, they're going to go through a grieving process. They're going to be devastated by the information initially. But they remember that, and they may only remember little snippets of stuff, but it's really important to make it about them and about their child and about some of the more positive aspects of Down syndrome with that initial conversation.
Yeah, and I would add that really providing a family with resources and what's available in their community, or even just on Facebook or online, or some kind of connection to others that is being directed by whomever they're speaking with is better than just heading to Google, because that is a very scary place. And I'm sure the medical community is perfectly acutely aware of, what is this bump, and then all these things come up, and Down syndrome obviously isn't quite like that, but it can be really terrifying for a new family and left to their own devices without any support and guidance from the medical community could be really devastating for that early phase of processing the diagnosis. So I would also just add that in addition to saying congratulations, if at all possible, not saying I'm sorry, because these moments, as Dr. Manickam said, are flashbulb moments in a family's life. My brother's 38, and my dad and mom could both tell you where they were sitting, who said it, what words were said or not said. They remember everything about it. And I think that the medical community might be surprised to know that it's that significant of a moment. And it's extremely powerful. And when it goes well, I think it sets a trajectory that's straight up. And if it doesn't mean that the family will never get there, but it's not quite that road. And so it's really, really important in the beginning to take that extra minute with a family.
And it's different also from some of the things that we have to do as physicians. We deliver bad news all the time, but it's different. We don't use the language of fight this disease or beat this disorder when we're talking about Down syndrome. This is your child. There is no cure for Down syndrome. This is who your child is going to be for their lifetime. And so we don't use that same kind of language because it's about acceptance. It's about inclusion. It's about getting them comfortable with the diagnosis. And now there's a bigger community out there for you as well.
Mm-hmm.
Yeah, all very, very important things. And you're right. We don't always think about being intentional when we sit down for these conversations. Like we have an agenda in our head, like we have to get this information out. But really, maybe it's best to take a pause before you sit down with the family and really think about how you're going to present this. And especially with the understanding that this is going to be such a flash moment for this family, that's something that they're going to remember. We want to be compassionate and inclusive and let people know we care.
It's supposedly Teddy Roosevelt, though I've never actually found the actual documentation that was something to the effect of, I don't care what you know until I know that you care. And I think that really does apply in this situation, that you can flood the parents with new information. They're not going to take that in. What they want to know is that you're talking to them about their child and you're using the right language and you're being empathetic. And I think that'll get the initial information. And yes, there are going to be medical things and so forth. But that at the beginning makes a big difference.
Yeah. Yeah, absolutely. So I think that one of the reasons that Down syndrome causes anxiety in parents when they first hear this diagnosis is because of the well-known impact that this condition has on intellectual well-being and mental health. And so what can we really expect? I think it's probably a fear of the unknown, because you don't know what the future is going to look like from an intellectual capacity. And so how do you discuss that with new parents?
So, again, one of those things I often say to families, but because it is really true, if you ask me to look in a nursery or a NICU and say how a kid's going to be in 5 years, 10 years, 15 years, I have no idea. And really, we have to start thinking about that in the same way for kids who have Down syndrome, that they are the adults with Down syndrome are doing things I don't think that anybody expected that they would be able to do. Not from the standpoint of we were putting limitations on them, but, we thought that there was an intellectual disability that would significantly impact them over time. And yes, they will have an intellectual disability. I'm not getting around that. But how much it impacts them is really about us as physicians and about families and about the school systems and the entire society about how we support them, because they're getting married, they're going to college, they're getting driver's licenses, they're raising their own families. They're capable of any number of things, and we should not be putting any limitations on them, and we really need to just support them as much as possible.
Yeah, absolutely. And along those lines, the American Academy of Pediatrics recently came out with a guideline on the health supervision for children and adolescents with Down syndrome. And I'm going to put a link to that document in the show notes so folks can find it easily over at PediaCastCME.org for this episode 86. It'll be in the show notes. And of course, there's a lot in this document, more than we're going to be able to cover during this podcast. So you definitely, if you take care of kids with Down syndrome, you want to go check this out. But what are some of the highlights, Murugu, that we should all keep in mind as we're caring for these children?
Yeah, so one of the things I really like about the AP guidelines is that they've broken out by age. And so they have what you should be doing prenatally, what you should be doing right after birth, what you should do from birth to 1 year and 1 year to 5 and so forth. And I think that really does make it a lot more user-friendly for the families. There's a version of this that's available from, I think it was Indiana University that did it originally, but it's a checklist. And I think that works for a lot of families, that they can go down the checklist and say, this was taken care of this year, this was taken care of, this is taken care of. And it's also good for even pediatricians and primary care physicians that you have the ability, okay, these are what the screens are supposed to be, and make sure that we're checking those boxes and getting the things done. Because some of these are ones that, you're going to see a handful of kids in your practice, perhaps, who have Down syndrome. And so it's hard to remember every single little detail, but when you have the AP guidelines, it's really nice. I'll also mention, the guidelines are now over 20 years old from the first version that I think were released in 2001, if I recall right. Mm-hmm. And they've evolved. They've evolved because they're going to be evidence-based. And so there are things that we used to think of as being high risk. For example, the axial atlantal instability. It used to be that we have to always screen these kids every year with an X-ray, and that proven to be false. Unfortunately, the X-ray is not good at really picking up if there is an increased risk for having subluxation. And so we want to go more off of symptoms. But we've also, in the last couple of years, and this newest version includes it, that we have to look at how kids are screened for like anemia differently. That looking at for microcytic anemia doesn't work in iron deficiency for kids who have Down syndrome, that you really have to look at the iron studies themselves. Kids naturally who have Down syndrome, they're actually a little bit macrocytic, and so you can't use the same judgment as you would for a typical person.
And more other highlights of the document?
Yeah, so one I make sure that people really aware of, because it really is hard to pick up otherwise, is thyroid screening. Very common in those with Down syndrome. About say 1% per year will actually develop thyroid disease, and most often it's hypothyroidism. And a lot of the symptoms overlap with what you would think of as somewhat typical features for children and adults who have Down syndrome. Things like weight gain, slowing down, constipation, those kinds of things. And it's something that's so easily taken care of as far as treatment goes. I think it's one of the more important ones.
Yeah, absolutely. Does delay in the diagnosis and treatment of hypothyroidism cause a difference in long-term outcomes for these kids?
Yeah, it will impact their intellect. It'll impact things like constipation, stool habits. If they have constipation, then that just makes it that much harder to toilet train when they get older. And so you really want to address those. And it's obviously going to affect growth as well.
Yeah, absolutely. So this, the Health Supervision for Children and Adolescents with Down Syndrome from the American Academy of Pediatrics, I love that it's broken down by age. It's got the checklists of what to look for. And as you mentioned, that's going to be helpful for families as well, not just medical providers. So as a medical provider, maybe you can let your families know that this exists, and that empowers them as they're advocating for their kids and making sure that what needs to be done is really getting done. So very, very important. And again, we'll put a link to that in the show notes. Kari, part of supporting kids with Down syndrome and teenagers is really going to be for us to understand what life is like for them, so that we can maybe start to anticipate needs, that we can have empathy and connect folks with what's going to be helpful for them. Kind of take us through what is a day in the life like for a family impacted by Down syndrome?
Well, that's a great question. I think it's different for everybody, of course, to some end. In the beginning, I would say that the majority of families feel very overwhelmed. They're thrown into an entire system, and with services and government type of public programs, and they just have a lot of information being thrown at them, and they may have just thought they were going to have a typical baby that they're going to take home, and that was going to be it. And maybe if it's their first child, that was going to be enough to overwhelm them. And so throw in a surprise diagnosis and sprinkle that with a couple co-occurring health conditions, and with the cherry on top being a complicated not politics, but these governmental entities that are there to help support and serve. But when I do trainings to the community about what families experience, in the beginning, it's like, who are you? And like, what are you doing here? Because it's very, very overwhelming to be navigating early intervention services. Typically with children with Down syndrome and babies, they're needing physical therapy, occupational therapy, speech, sometimes feeding therapy, may have heart issues that are being monitored, pulmonology. That's a lot. And then that's not even looking at some of those other developmental components that you would want to support for any baby. So I think it's just really important to note that in the beginning, you may be repeating yourself often. You really should lead heavy with community resources that are available. If there's a Down syndrome association in your area, that's a great start. Every Down syndrome association is its own functioning entity that connects with the national organizations, but they're usually their own separate 501c3. That's important to note because when you look at the robustness that they might have to offer, it might not be as expansive as what we have at the Down Syndrome Association of Central Ohio, but every single one does have a really solid beginning type of, early support type of programs. Even if they're just completely volunteer driven, that's like, they've got that. They have that first connect, that first call program, and those things, which can be really helpful for a family in the beginning to, at minimum, maybe they don't want to come to a group. They're not ready for a big event, but they do want to talk to another parent who's experienced what they have been experiencing. And that is an invaluable piece that any Down Syndrome association in the country will have that. And I just think that in the beginning, that's a really important part. I have to say all of that because if I led into what I'll say next, then you might not, believe it to be true. But after the beginning, I would say that the majority of families will report to you that they feel very lucky. In fact, in our community, there's this common phrase called the lucky few. And it's a little bit of a play on the trisomy part, but also just this, when you look at the prevalence, not that many people get to have a child with Down syndrome. And when you look at, not to get too philosophical here, but when you look at what life is all about, if it was easy all the time, you might not appreciate it the same way. You really look at your life as what you've been able to overcome, what obstacles you've had to work through, who was there to support you in those challenges. And it makes it that much sweeter on the other side when you do accomplish those goals and those dreams and that vision, even if it takes longer. So we see a lot. I can't say 100% of the time. It's certainly not rainbows and sunshines and unicorns all the time. Sunshine and unicorns, it's just not. But there's an overwhelming majority that will tell you it's tough, and they'll tell you that there's heartache because there is. It's difficult to perhaps see even their younger siblings or their peers surpass them with some of the developmental milestones. But the wins, focusing on the abilities and the strengths and the gifts of their loved ones with Down syndrome is an incredible gift that you can't always see so clearly with a typical child. But you really, really begin to embrace that when you realize that you are investing all of that time and energy, and look how hard they're working, and they still did it. They still learn to walk. They still learn to talk. They're making friends. They're doing things out in their community. My brother's 38. He just started volunteering. I have many, many other family members who do not volunteer their time, and they do not have Down syndrome either. So, he gives back. It's not even just about survival. He's thriving. And I think it's really important for families to hear that and see that. And that's going to come from a physician in the very early days, talking to them about what is possible. We talk about fullest potential at the Down Syndrome Association of Central Ohio. And we talk about providing a lifetime of opportunities. And the medical community is just a piece to opening up doors to those opportunities. But educators and neighbors and so many others, employers are a part of that process along the way too.
Yeah, it seems like this is really a case of it taking a village to help a child reach their full potential. I mean, there's certainly going to be important things happening in the home, but as you mentioned, also the school, social service agencies, all the medical professionals that may be seeing that child, from the primary care doctor to, perhaps a cardiologist or a GI doc or, whatever other issues that they may end up having. And all of those people combined really are important for the eventual development of this human being.
Yeah. And I think it can be really terrifying because, with any life-changing diagnosis, whatever it might be, and I would deem this as one of them, you don't really know who is going to be your village. You think you might know, and then you might be disappointed in some people, and then you might find this beauty in people that you never really expected to step into your life and support you. But that's difficult too, in and of itself, no matter the diagnosis. So we hear from families, my parents aren't embracing my baby that was just born. And that's, extremely difficult and painful. It doesn't mean it always stays that way, but I think it's important for the medical community to know that there isn't necessarily that instantaneous village that's just going to rise up. And so that's why, again, not to sound like a broken record, but pointing families to those resources. I wish we weren't, in some cases, the only support to a family, but sometimes we are. And connecting them to a family that they didn't ever know, but now they have this commonality is usually life-changing for those types of families in particular.
Yeah, and I think it's also really important that, and part of what the Down Syndrome associations have really done a great job of is educating everyone about what the possibilities are. You talk about the grandparents who have this view maybe of Down syndrome that they thought about 30 years ago, and it's very different. And, the same happens for pediatricians too, that, if you've been in practice for a long time, you might have a view that you were taught in school, but it's different now than it was before. And I talk about the generational differences, that it's a huge generational difference of 30, 40 years ago where they wouldn't have done cardiac surgery for a baby who had Down syndrome. And then in the 1980s, they started to, and some of it was realistic, bypass was not something that was commonly available, so it's not necessarily easy to do. And then over time, the next thing was getting those therapies started early was really important. And then schools adapting. And, really importantly, that inclusion matters, that kids with Down syndrome do so much better in a mainstream classroom because they're really good at watching what other kids are doing and wanting to do that. That's how they learn best.
All kids are better. When children are included. All the kids, not just the children with Down syndrome. I think that's a really important note that sometimes people might view it as a bit of a charity case, like, oh, well, it's better for them, I guess we have to do it. It's research has shown it is better for all children and adults.
Yeah.
Inclusion creates a better workplace environment. There's tons of data on that. And we see it from childcare all the way up through to adulthood.
Yeah, absolutely. And because when you see the challenges that other people face and the shoes that they walk in, you start to have empathy for people. And that's how we connect and we engage and relationships form. And it's just so important. And so I'm really glad that you have focused on that. I feel like if we had recorded this podcast 10 years ago, we would be talking about they got to see this specialist and that one and this one. But just as important of that is the positive attitude of looking, how is this child the same as people in the family? How they can go to school and that positive attitude really then spills over into the child with Down syndrome, their attitude and what they can accomplish and the feelings of success that they can have. And all of this is so important for medical providers to understand, just as important as the medical part.
Mm-hmm.
You even think about how many, you just see kids with Down syndrome in normal ads and from Target, and you see them in television shows and things like that. And that does matter. When you see somebody who looks like you or you recognize them as having Down syndrome, that does matter.
Mm-hmm.
It makes you feel more welcome.
Yeah, absolutely. We're going to have a lot of resources in the show notes, certainly to the National Down Syndrome Society. They have tons of resources, educational modules, links to support groups, advocacy opportunities. The National Down Syndrome Congress is another one. Of course, the Down Syndrome Association of Central Ohio, who Kari is leading. We'll have a link to that in the show notes. Also, the Special Olympics. We've done shows on the Special Olympics before, but that's another organization that really kids with Down syndrome can be an active part of and experience success through sports as well.
Just for timing, just this last weekend was the opening for the Special Olympics in Germany, and just watching it was amazing.
Yeah,
so many kids with Down syndrome you would see among the athletes. And it's how excited they were to be there.
Yeah,
it was moving.
Absolutely. And we did an episode on our parent program, PediaCast. It was episode 434 on athletes with disabilities and adaptive sports medicine. And so if you're interested in hearing more about Special Olympics and the opportunities that organization has, definitely check out that episode of PediaCast. And I'll put a link to it in the show notes as well.
And I think that all of those offerings are wonderful. I also would encourage the medical community to just inquire about what's available through school clubs and sports, and just seeing if that type of thing is something they're willing to explore. I will be the first to say that there's an emotional risk tied to that for a family, because there's a chance, and I don't know the percentages, so I'm not going to purport to know, but there's a chance that they might say, we can't safely, have your child participate in this, or we're not sure that we can meet them where they are to provide that inclusive component. But there's also a chance that they'll say, yeah, let's give it a shot. Let's see if, maybe they're not going to be the star in the play, but they can help with whatever it is that they like. If the person's really into technology, maybe they're helping with the lights and, whatever strength that person might be able to bring to a situation. I want to make sure that we're continuing to push the envelope on that, because I'll be clear, I've been a Special Olympics coach on and off for a number of years. I think it's a great program, and I certainly think that it's a great free resource to many, many families. But I've also been raised in a household where, my brother ran on his cross-country team. It didn't matter if he was second to last or first or dead last. His participation with his peers went a really, really long way. And, team individual sports might be a better approach than joining the volleyball team. But, that's the type of thing where if we can continue those conversations with what might be available in the community, particularly if there isn't a ton of different sports available through Special Olympics, or even if there are, it's a nice supplement to look at what might be available, dance classes or music lessons, whatever that might be of interest that are inclusive.
Yeah, absolutely. And I would imagine that's another reason why getting connected with a local support group is going to be so helpful, because they're going to know what resources are available in a particular community, or maybe which instructors have worked with kids with Down syndrome in the past and had success with that. And so you really do get an idea of where you can get pointed in the right direction based on your local resources.
Well, and we can also help advocate if the answer is we can't. I think that's a piece where in the past we have offered to pay for that extra person that they say they have to have in order to safely provide an inclusive swim lesson, for example. And whether or not they take us up on that helps us understand what the real issue might be. And so we are in a position to really empower that family that might take that emotional leap.
They're both somewhat local groups, but they've really gone nationally too. So one is a group called Improveneers, out of a dad in Akron who has a son with Down syndrome, but he's also a stand-up comedian. And so he's actually adapted a stand-up comic training program for adults with Down syndrome, which has been really helpful. I mean, Kari could probably give you more details, but it helps their self-esteem. They become better communicators. They're able to, joke, and it just becomes so much more natural. And it was just with a little bit of training through him.
Mm-hmm. Yeah, it's a really natural way to teach communication, because improv is all about listening to the other person and then responding to what they have to say. And I think over the years, there have been different kinds of models of like teaching people how to have conversations. And it feels very, no offense, but like clinical and like not, it doesn't feel natural at all. And improv has proven to be a really powerful way to encourage, that back and forth communication.
Yeah, and we'll put a link to that in the show notes as well. We'll hunt it down so folks can check out that resource.
There's another also group that started up as something called Buddy Up Tennis, where they really started here in Columbus as a mom whose son wanted to learn how to play tennis. And she worked with her older son's tennis coach, and they developed this method to teach her younger son with Down syndrome tennis, and it expanded locally here. Now they have like 60 to 80 athletes on a given Saturday playing tennis together, and is also now at 25 centers around the U.S. And it really is amazing. And even small Down syndrome communities have supported these kinds of groups. It doesn't have to be a big one, but again, it helps with self-esteem. It helps with team building. And a lot of the families will talk about how excited their kids are to go to tennis every Saturday morning because they look forward to it so much.
Mm-hmm.
Yeah, that is really awesome. And you said that was called Buddy Up Tennis?
Buddy Up Tennis now originally started as Buddy Up Tennis, but now it's Buddy Up for Life.
We'll put a link to it in the show notes so folks can find it easily. All right. So one of the things that's going to happen with pretty much all kids with Down syndrome is they're going to grow up and they're going to transition from pediatric healthcare, hopefully, to adult healthcare. What does that process look like? And what is the role of the primary care doctor in helping facilitate that transfer?
Yeah, that's a really good question. I think one that we're still trying to figure out the details too. So, when we do a lot of these transitions, we're really thinking about the teen who's supposed to start taking more responsibility for their own healthcare. And we're talking about somebody who does have an intellectual disability that may be a little bit harder to do. And the other part is, kind of the social side to it is that they're going to be in high school for a little bit longer, and they're going to have that structure of school and scheduling and things like that mean that it's going to they don't need the same kind of support early as they do when they start to do that transition a little bit later. We even talk about with their developmental issues, and they go through puberty and they go through the streak of independence that teenagers naturally are going to do just a little bit later. They do it in their 20s. And so some of that is the natural maturity that occurs over time. So it happens a little bit later. So that's also when you want to start timing to think about that transition to an adult provider. But the big problem, though, really is going to be that it's hard to find adult providers who are comfortable taking care of adults who have Down syndrome. Mm-hmm. You think about most internal medicine physicians, they're going to have maybe seen somebody with Down syndrome when they were in medical school. That might have been the last time. And, we talked before about the generational thing, and that's the next big barrier that we're really trying to figure out how to best take care of adults who have Down syndrome now, because that's something that they weren't in that area before. So I think one of the things I kind of really try to emphasize is I think it's important to have a primary care physician who's a primary care physician and find somebody to help take care of the Down syndrome thing. There are Down syndrome clinics around the country that are available and happy to help out where they can. There are some adult-specific ones that are available as well. And there's lots of resources, including guidelines that just came out now 3 years ago for adult guidelines for adults with Down syndrome. And those are going to take care of, those check boxes that we talked about from the AAP before. It's the same thing for adults. And so finding just somebody that maybe a parent's comfortable with, and they already know you as a person. And so it helps to have that connection to a primary care doctor. And that's the first thing to do when you start thinking about the transition.
Down syndrome clinic to you, that resource, I think, can help equip a family with information. They can fill out a survey online for their teen or adult and really begin to plug in what ongoing health needs there may be. And it really, not technical term, but it spits out something that you could take to a physician to maybe then evaluate the need for referrals and things of that nature. So it's not a perfect it's not going to give you everything, but it'll give you a solid start, particularly if you do not live in a community that has an adult Down syndrome clinic, which many communities do not. I think there are 10 across the whole country. So
more than that. They're still few and far between.
We're lucky living in the 14th largest city in the country to have one, but many, many other cities do not, or perhaps those adults and their families don't have the capacity to travel to get to one. So when we look at accessibility, it's certainly, again, not a silver bullet, but the DSCT2U site could be a helpful start with really considering what healthcare needs that particular person might have.
Yeah. And we'll put a link to that in the show notes as well, so folks can at least,
Yep.
If you're interested, especially if you're not near or if you're living in a community that doesn't have a lot of local resources, this may be something that's helpful. And we'll put that link there so you can check it out. And then we'll also put links. I'm assuming that you're talking about the caring for adults with Down syndrome from the Global Medical Care Guidelines for Adults with Down Syndrome. And then it was also published in JAMA, and I'll put links to that in the show notes as well, especially if you are an adult provider. And here's where I think it's really going to be helpful. If you're pediatrics and internal medicine and you have a practice with both, you have colleagues that are just internal medicine, most likely. And then maybe you can share, maybe you're listening to PediaCast, but let your adult colleagues know that these resources are available for treating adults with Down syndrome and having those check boxes and, really having an idea of what you need to do to be providing the best care for them. That can certainly be helpful. And again, I'll put a link in the show notes for that. So when you have a condition that's as common as Down syndrome, we're talking 1 in 700 births, you're going to have Down syndrome present, I would assume, in lots of different communities. And so different ethnic backgrounds, different socioeconomic levels. And so as we have people from different backgrounds and with different access to resources, you can start to have a disparity in healthcare in terms of what's available. Is that true with the Down syndrome community, Murugu? Do you see disparities in their healthcare?
Yeah, unfortunately, absolutely we do. I think there are a couple of things you can think about. So we talked a little bit about, the facial features are a little bit different in other communities than they might be in somebody who's of European ancestry. And most of us had textbooks that kind of showed only Caucasian children who had Down syndrome, but the facial features are a little bit different. And so sometimes the diagnosis is a little bit delayed. But we also know that there are other parts to it that are going to happen, unfortunately, across the board of poor prenatal care for those in lower SES groups. And then in the long term, there's also concerns about, the quality of care, the access to resources, things like that. And the same starts to hold true when they get into school age as well. We know that schools are going to have different levels of ability to support those of different abilities. And so it really, unfortunately, runs the gamut that we will end up seeing.
Yeah. And I would suspect that's something that primary care providers are going to want to be aware of, to know what resources are available for and how to connect people with those despite different backgrounds. And so here in Central Ohio, Kari, how is the Down Syndrome Association of Central Ohio dealing with and helping folks get over that barrier of disparity?
Yeah, well, the first thing that we were able to do is because, Down syndrome occurs in people universally among races, ethnicities, and socioeconomic, we can just look at the census data to compare to our membership database to see how we're doing. And that was really where we started years ago, of really looking at if 95% of our membership is Caucasian, yet that's certainly not the Central Ohio demographics that we know exist, which has continued to move even more so with the latest census data. We know that we had a long way to go. So I think just looking at where you are was an important factor for us, and then where we wanted to go and where we wanted to head. And when you're looking at some of these communities, particularly in Central Ohio, there's a significant Somali community, you have Latino Hispanic community, of course, the Black and African American community. There are many, many others, but those are, some of the largest demographics of minority groups in Central Ohio. We had to look at really a lot of cultural awareness, because what we heard from many people, depending on which kind of group we were speaking with in our learning and listening sessions, is that there are communities who want to pray it away, or just ignore the diagnosis altogether. And while I may or may not disagree with that, I have to know that is a barrier to access and be aware of those cultural components that might limit someone's or might create a barrier to access or interest in accessing supports and services. So we've made a vested effort over the years we hired people on our team who can be a liaison to the communities we aim to serve. And we look to places like Our Lady of Guadalupe here in Central Ohio as a referral resource and someone that we can build relationship with. We are on the La Mega radio station and on their TV channels, and we consistently have a presence. And I'd be lying if I said that overnight we just exploded with all these different diverse families. It's taken years and years and years, but we are eking closer to that 25% demarcation of different minority groups who we're now serving, compared to 5%, 7 or 8 years ago. And we're working really hard too to not just count them in our membership database, but to really meaningfully engage and ask questions specifically to them on how we can be better and what we can do better and what's most meaningful to these groups, and meeting them where they are in the city, and not necessarily when we look at accessibility, I think in our world of developmental disabilities, we're already talking about accessibility all the time, but there are lots of extra layers to that, with language barriers and things of that nature, in addition to some of the physical barriers that accessibility oftentimes you'd see. So we are invested in it, and it's a long game. And I think that we've certainly made missteps. It's been awkward. And I tell my peers and colleagues across the country, if it's not awkward, you're probably not doing it right. Because we have thought one thing and tried it and it didn't work out. And you have to just really be humbled by continuously learning and making missteps. But one thing that I can say I hear repeatedly from the communities that we aim to do a better job in serving is that they can tell that we care and that we have a passion for getting there. So even when we quote unquote mess up or make a misstep, they know that we're trying, and then that just continues to gain that buy-in. They say, we hear this all the time as we see these initiatives from different places where they want to serve us and then 6 months later they're gone. And they kind of gave up. And we can't have people giving up on us because it's too important. So I would say that that's been a huge area of focus, but making that investment in paid folks, not just volunteers that could come and go, has been a game changer for our organization.
Yeah. I love how you figured out that there was a problem. And I think that this is a lesson that folks who have similar organizations across the country, not here in Central Ohio, but elsewhere, that's supporting folks with Down syndrome, is to look at the demographics of the people that you're serving and then look at the demographics of your city. And if you see that those aren't matching up, then there probably are communities of people that you're not reaching. And then you just have to think out of the box of how are we going to reach those folks. And as you said, it's going to be trial and error. And that's how you get a fantastic program, is by making missteps and figuring out what works best. And have you had other associations from other communities reach out to you to ask how you've done this? Or are you willing to help other communities out there?
Of course. Yeah. We often present at national conferences on different things that we do, but this has been one that we've been asked to speak about a couple of different times now, because we do have a paid social worker on our team, which is very unique to us. There may be a couple other across the country who have that licensing, but they're not necessarily in that role doing that work. And Kirsty on our team has been really doing a great job she manages our family engagement, and she has a hyper focus on meeting the needs of families that may not otherwise just reach out to us, and she reaches out to them. And I think in that way, we're very lucky. Central Ohio is a very giving community. We have a lot of incredible donors that have afforded us that ability to hire a social worker and paid folks for that can speak Somali or can speak Spanish or whatever language. We have translation services that we can pay for. But we're in a good position here in Central Ohio, and we're really honored and of course want to share what we're learning, because if we can make it a couple less years for someone else's learning in another city, then that translates to dozens, if not, hundreds of families in those communities that now might have access earlier to the programs and services that the local associations have to offer.
And Kari's being humble because they've won awards actually for the work that they've done.
Well, we have a great team. We do. And we're really lucky. I will also say that we have a really collaborative community here in Central Ohio. And I believe that there's, that's been studied, the public-private partnerships and nonprofits. And I think that when you are humbly and passionately in this space, you can find other partners that have your shared goals, like Our Lady of Guadalupe, or, there are many, many others in Central Ohio, but that's one that has been incredible with us. And they're not territorial. I think that you can't be territorial and get that work accomplished. And so I'm not saying that that it's impossible for other communities or that we're lucky. We work really, really hard at it. But we are fortunate that we're in a community that is not territorial in that way, because we see that need, and we want to help people here. So thanks, Dr. M. That was nice.
Before we go, Kari, if you could tell us a little bit more about the Down Syndrome Association of Central Ohio and how folks here in Central Ohio can get connected with your group.
Yeah. So I think, the most relevant thing to say in this day and age is through social, right? So we do have an Instagram handle. I believe we have TikTok. We have Facebook and all of that stuff. But we did actually in the last year launch a handle that is specific to expectant mothers and fathers. And it's a handle at Expecting Extraordinary. And, I think that a lot of the time when we're talking about the family's experience, we are focusing on the positive, the wins, and the successes. But what that can mean, it can feel very alienating for a new family who might not be feeling that way. And so we created a page that really was an honest space with interviews and experiences from families who are now out of it. But in the beginning, this is how they felt. I actually think that it could be really interesting for the medical community to see some of that, because it does really illustrate beautifully kind of the bittersweet feelings and emotions and the fear that a new family faces when they get the diagnosis, but it also creates a really safe space for that parent who hasn't reached out to any resources yet. They're still processing, and to know that their feelings are okay. So we have that handle, which isn't necessarily on paper. You wouldn't see that as directly tied to us, but that's a resource. We have our website that dsaco.net. And we also are available in our offices and by phone and email and all that stuff too. We've got a really, really incredible team of passionate people. Some of them are siblings like myself. Some of them are parents, and some of them are just really awesome people who love our community. And, even for me, I was welcomed into this community back when my brother was born in 1985 as the big sis. And when I started at DeSaco, when I started here at this organization 10 years ago, I was like, what do they even do? I didn't know. And I thought, am I even going to be busy? And now I laugh and I cry thinking about those beautiful days when I thought I wasn't going to be busy. But it was surprising how much we have to offer. We really pride ourselves on offering services and supports and programs to families throughout the lifespan. We offer new parent counseling services so that it can set a solid foundation for those that maybe they're interpreting the diagnosis and processing it very differently. And we want to help create a stronger foundation at the start. And then we have things all the way to end of life groups for parents who have adult children who they're seeing dementia and Alzheimer's, and they're working through that together. So every step of the way, we can be there, because every step of the way for a family is unknown all over again. It's when in the beginning it looks one way, and just as you're getting the hang of it, you're moving into school. And then just as you're really getting through the groove, it's transition time. And then it's, what is this employment stuff all about, and living and being independent. So, but we're not the only ones in the country that have that. There are many, many incredible Down syndrome associations throughout the country that offer really innovative programs and supports to families. We're lucky enough here in Ohio that we also offer a supplemental learning program called Learning Aid Ohio in partnership with the Governor's Children's Initiative, the Department of Developmental Disabilities, and the Department of Education, as well as a new program that we're launching called Adult Literacy Ohio in partnership with the Down syndrome, with the Department of Developmental Disabilities and the Department of Education. So we're really excited about that. We're probably doing a little bit more in that respect than some of the other Down syndrome associations do, but many offer different social events and really just places for families to connect and engage with one another. And I would say on a survey that we did last year, one of the most powerful ways that our families feel connected to us is through our private Facebook group. They can post in there, hey, my daughter just started her period and I don't know what in the heck I am supposed to even do. And, or my child wants to date somebody now and they say they want to get married and I don't know how to process this and what to say and what not to say. And those community connections are so powerful for families, and every Down syndrome association across the country can offer that to a family.
Yeah, so important. And again, we'll put a link to the Down Syndrome Association of Central Ohio in the show notes for this episode 86 over at PediaCastCME.org, so folks can find you and get connected with you pretty easily. So once again, Kari Jones, President and CEO of the Down Syndrome Association of Central Ohio, and Dr. Murugu Manickam, Clinical Geneticist at Nationwide Children's Hospital. Thank you both so much for coming and sharing your expertise with us today.
Thank you.
Thanks for having us.
It's amazing.
We are back with just enough time to say thanks once again to all of you for taking time out of your day and making PediaCast CME a part of it. Really do appreciate that. Also, thanks to our guests this week, Dr. Murugu Manickam, Clinical Geneticist at Nationwide Children's Hospital, and Kari Jones, President and CEO of the Down Syndrome Association of Central Ohio. Don't forget, you can find PediaCast CME wherever podcasts are found. We're in the Apple and Google podcast apps. Also, iHeartRadio, Spotify, SoundCloud, Amazon Music, and most other podcast apps for iOS and Android. If you like what you hear, please remember to subscribe to our show so you don't miss an episode. And reviews are always helpful wherever you get your podcasts. So we appreciate when you share your thoughts about the show there. And then don't forget about the landing site, PediaCastCME.org. You'll find our entire archive of past programs, along with show notes for each of the episodes, CME information, our terms of use agreement, and that handy contact page if you would like to suggest a topic for a future episode of the program. We love connecting with you on social media. You'll find us on Facebook, Twitter, LinkedIn, and Instagram. Simply search for PediaCast. And then don't forget about that CME credit, Category 1 credit, absolutely free. You've listened to the podcast. Now be sure to claim your credit. Easy to do. Just head over to the show notes for this episode 86 over at PediaCastCME.org. You'll find a link to the post test in the show notes. Follow that link to Cloud CME. Take and pass the post test, and the Category 1 credit is yours. Super easy, right? And again, we offer credit to doctors, nurse practitioners, physician assistants, nurses, pharmacists, psychologists, social workers, and dentists. So you'll want to be sure the content of the episode matches your scope of practice. And as I had previously mentioned, this episode will pretty much match everyone's scope of practice because it's very likely that you're going to be taking care of kiddos with Down syndrome at some point in your career. Complete details on the CME, by the way, is available over at PediaCastCME.org. Don't forget also about our podcast for parents, PediaCast. A lot of pediatric providers also tune into that one. It's an evidence-based podcast. Lots of different stuff we cover. Pediatric news. We answer listener questions. We interview pediatric and parenting experts. Shows are available at the landing site for that program, PediaCast.org. Also available wherever podcasts are found. Simply search for PediaCast. Thanks again for stopping by. And until next time, this is Dr. Mike saying stay informed, keep it evidence-based, and take care of those kids. So long, everybody.
This program is a production of Nationwide Children's. Thanks for listening. We'll see you next time on PediaCast CME.